Coming up today, a misunderstood condition with symptoms that mimic dementia. How to get the right diagnosis, plus the clinical trial hoping to get FDA approval. Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. We all have fluid flowing in and around our brains. It is incredibly important for protection, nutrition, and more. And when too much of that fluid builds up, it puts pressure on the brain. It can lead to symptoms that look and feel a whole lot like dementia. For John Kiger, the biggest symptom is difficulty walking. Instead of taking steps, he shuffles, almost like magnets, keeping his feet on the ground. Angie Racono shows us the clinical trial that has John hoping for a steady stride.
Never had anything done like this.
John Kiger is the first person west of the Mississippi to get an e-shunt. The procedure recently took place here at the University of Kansas Health System, one of just 12 clinical trial sites across the nation. John recently learned he has normal pressure hydrocephalus, extra fluid on the brain. It can mimic signs of dementia with brain fog and an unsteady shuffle.
My walking, falling, mainly the falling. I fell in front of my boss at work.
The good news for patients like John is that we are studying a new approach. Traditionally, it requires surgery and an implant, a ventricular peritoneal shunt. But now there's a new option being tested. It's smaller and less invasive, and we hope it will soon be approved by the FDA.
They have developed a device that's this big, instead of 3 feet long, that's delivered in a non-surgical way. It's delivered by catheters without incisions.
Dr. Koji Ebersol is an endovascular neurosurgeon who knows how problematic shunts can be.
It doesn't matter how meticulously you do it. You don't control the fact that you are implanting a 3-foot-long mechanical system into a biological system, and you cannot control whether that marriage is happy. So no matter how perfectly you do the shunt, you have to accept that almost half of these are going to fail within the next 2 years. That is too high of a number because failure means repeat surgery.
The clinical trial testing a new procedure to install the e-shunt involves interventional radiology. The e-shunt is delivered through a vein to the base of a patient's skull, which then regulates the amount of fluid. Patients may even go home the next day.
We are extremely optimistic that this new advance may be able to treat the condition with much more physiologic drainage and without all of the burden associated with trying to protect a 3-foot-long mechanical implant.
For John, an e-shunt offers fewer potential complications. What is the hope with this procedure for you?
Me, lift weights and pickleball. I like to try pickleball because I used to play tennis a lot. I play with my puppies.
Those are good goals.
And we do thank John for being a part of a public trial and talking about it with us. The rules of the trial mean that we cannot reveal his results until the very end. So we do wish John the very, very best. We do want to make it very clear, though, as we get into this conversation this morning, that this is an investigational trial. It is not an FDA-approved option for patients yet. But to talk more about that possibility today, here at the desk with me is Dr. Koji Ebersol, the Director of Endovascular Neurosurgery here at the University of Kansas Health System. Always great to have you.
Thank you.
And I guess you're meeting Dr. Matuk today for the very first time, Dr. Charles Matuk from Yale New Haven Health, where he is the Chief of Neurovascular Surgery, as well as the Director of the NPH and Disorders of CSF Dynamics program. He is the lead principal investigator for the STRIDE trial that we are talking about here this morning. So great to have you with us, Dr. Matuk. How are you?
Great to be here this morning. I'm well. Thank you.
And I know you and Dr. Ebersol are quite well familiar with one another, but have not met yet. So I want to introduce you to Dr. Koji Ebersol.
Hi, Dr. Matuk.
Hi, Dr. Ebersol. Great to meet you. I hear great things, and congratulations on your success in your program.
Thank you very much. Thanks for having faith in our capacity here.
Yeah, so it's exciting to have both of you here to talk about this. Dr. Ebersol, let's start. What exactly is NPH, normal pressure hydrocephalus?
Right.
Why is it often mistaken for dementia?
Normal pressure hydrocephalus means an excess of accumulation of CSF, the natural fluid inside of the skull that's bathing the brain, that can happen increasingly as we age. This abnormal balance of the fluid system can lead to a classic triad of symptoms, meaning 3 types of symptoms that lead to the diagnosis. They are cognitive change, it's often memory dysfunction or brain fog. It can be loss of bladder control, so that you have even frank incontinence, meaning losing your urine without warning. And the most telling feature tends to be compromise in mobility, that somebody is slowing their stride and it's compromising their freedom progressively over time. When you put those symptoms together, it looks like a patient that may be suffering from dementia. But if it's normal pressure hydrocephalus, we can have a very meaningful treatment.
Dr. Matuk, do we have a good idea of how prevalent NPH is? Are there people that have it and don't even know it?
It's a relatively uncommon condition, I think, all things being equal. We know the prevalence increases with age. So below the age of 65, we think less than 1% of the population has it. But over the age of 80, we think 5 or 6% of the population has it. And just to your point, it's probably dramatically underdiagnosed because it's not really brought to the right doctor's attention often enough.
So how is it then typically diagnosed? Dr. Ebersol was explaining some of those symptoms, and they can present a lot like dementia or other ailments. But how would someone typically diagnose it when they do get to the right doctor?
The first sort of tip-off is that you have to have what's called a classical clinical triad. Triad meaning one of 3 things. So typically that means you're having cognitive issues to some degree. They're usually mild, but can be quite debilitating and disruptive to normal life. You have trouble walking, like the patient that you showed in the video during the introduction. And you have to have difficulty controlling your urine, which can either manifest itself as frequency, so you have to go all the time, or you can't hold your bladder, or actual incontinence, or you're having accidents. As you get older, any of those things in isolation is quite common, but to have all 3 together is less common, and that should trigger intracranial imaging, so a picture of your brain, either in the form of a CAT scan or an MRI. If you have that classical triad with enlarged ventricles, then the next step would be to do some kind of provocative test, which is essentially taking fluid off your back, which is connected to fluid in your brain. And if you have improvement, in particular in your gait, that's what establishes the diagnosis of NPH. And so it's quite a process to get there, but the initial trigger should be if you have that constellation of 3 things that we've talked about.
So we're talking about a trial today. Dr. Ebersol, what's the standard treatment for NPH right now?
So if you have a patient who has the clinical triad and they have a meaningful response to the lumbar puncture removes fluid from the compartment that houses the brain. And so the brain temporarily gets to experience the environment that it would be in if the fluid system was more balanced. Those patients can have very impressive improvement for 2 to 4 days or so in the symptoms that we're targeting, especially mobility. If you find that patient, you can give them that durable response by continuously draining the fluid off. That requires a surgical implant called the ventriculoperitoneal shunt, or VP shunt for short, and it is a tubular system that will essentially shunt the fluid from the brain compartment down to another area of the body, typically the abdomen, which is why the device tends to be 3 foot long.
So after you do that procedure, then how long does it take till symptoms improve immediately and then long term?
Right. Well, I will tell you that my personal practice is I am protecting the patients from an overdrainage problem. Overdrainage can create a new host of symptoms that can be dangerous. So since we do not know exactly what pressure to set the shunt at, I tend to set it at a high setting, and then over the course of multiple weeks, it can be dialed at the bedside with a magnet. We dial it in the office to slowly get it to the sweet spot without passing over into the region of overdrainage. The point being, after the surgery, it's still a commitment. It will take, for most patients, about a month before they start feeling the positive effects.
So let's talk about this approach as we're testing the e-shunt. How does it work? What makes it different from the VP shunt that you had mentioned?
To me, one of the most important differences is that the VP shunt is draining the fluid from the brain to a completely unrelated part of the body, typically the abdomen. The way that CSF naturally drains is from the fluid compartment in the brain to the veins of the skull. the e-shunt reestablishes that with a small device to recommunicate the CSF space with the venous space.
So we're seeing that here.
Okay. Yeah, this is an animation showing how you can access the venous system from a vein in the leg and then track your catheter system up to the veins at the base of the skull. And then a fine catheter will enter the target vein and allow a channel for the e-shunt to be delivered. That is the e-shunt there with the small anchor, and then the tubular system is the drain of the e-shunt. So it is communicating the fluid space with the venous space, which is the natural physiologic mechanism of that fluid resorption. So essentially you are reestablishing another channel for the brain to do it the way it would like to.
Dr. Eversole, you perform very complex and challenging procedures. We want to show some video from the first time that you implanted this device here at the health system. What happens during the procedure? How does it compare to other procedures that you perform?
Right. Well, the fact that it's catheter-based, that is our wheelhouse. That is what we do day in and day out. So many of the elements are quite natural. So you are accessing a vein that is typical for us to need to access for other medical conditions. So we'll take our catheter system and deliver it up through the jugular vein, which will allow us to get to the access of the target vein at the base of the skull. So as you can see, the tubular systems are quite long to reach this far. This is us accessing the venous compartment at the base of the skull. We do all of this work watching a large monitor, and then we're using our hands on the table. The patient is asleep under anesthesia, and we can see all of our instruments. This is a catheter here, a finer catheter there with the wire. We are trying to figure out what's the best path to come here into this side to create a stable anchor for delivery of the subsequent instruments.
Then we deploy it. Do we have the deployment?
There are a number of steps leading up to this. At this point, this is the delivery catheter of the device itself coming into the target vein, so we are getting quite close to bringing the device up. This is the actual device itself. Now, most of the device is invisible on X-ray because remember, X-ray works on density. So to see it, it has metal markers as part of the implant design. This is us. We have entered through the wall of the vein into the fluid space, which is where the target is. And we are now advancing the implant that we can visualize simply by those small markers there. And when the implant is fully delivered, it will seat happily in that space. And then you retract the rest of the system out, leaving only this small thing, of which we can only see those little tiny dots.
Wow. Thank you for the show and tell. Very, very interesting what you're able to do. Dr. Matuk, what are your thoughts on the potential of the e-shunt?
Oh, I think it's potentially going to be a great advance. I think, as we talked about, the prevalence of NPH is probably dramatically underestimated. And I think one of the reasons is that people don't think about NPH. So at a minimum, what this study is doing is the excitement that surrounds it is bringing attention to NPH, and that makes it top of mind. And I think more people will therefore, have the opportunity to get treated. The e-shunt device is also a much scarier proposition for a patient that doesn't have to have a hole drilled in their skull, which, understandably, people don't necessarily want. And so this, I think, will allow more people to feel comfortable moving forward with treatment that would be able to help them, but they're too scared to move forward with the standard treatment strategy. So I think it's a great device that has tremendous potential, and that's what this trial is designed to establish.
So this is being studied via the STRIDE trial. For a device like the e-shunt, Dr. Matuk, what kind of science and testing is required to gain that FDA approval?
It's actually amazing. So to get to this point has really been over a decade of effort from the people that first came up with the concept to coming up with a sort of commercial platform and prototypes, and then having the first in-human studies that were done in Argentina. You then have to perform what's called a pilot study. That type of study is focused on safety. So it's not really about how effective a device is, but can it be done safely? So that study's now been completed, and we're very happy with the results. That then allows you to move forward with what's called a pivotal trial, which is this randomized controlled trial, which is going to pit e-shunt against traditional VP shunt. And this trial is meant to establish its effectiveness. So it takes about a decade of establishing safety to the FDA to even get to this point, let alone to market.
And it all comes together when you find patients willing to step forward and be a part of a trial. Why is it so important to have enough patients in a trial like this? Why is that so critical?
It is so critical, and it's a noble thing to be part of a trial, because it will benefit people outside of yourself. So it's not only potentially good for you, but it's good for other people. Without the patients, we don't have the data that's required for the FDA to approve the device for the U.S. market. So if patients don't enroll in the trial, then this device dies on in the back rooms and never sees hospital shelves or the opportunity to impact patients' lives. So trial enrollment is critical.
Dr. Ebersol, what is having STRIDE here at KU? What does that mean for local participants?
To be honest, we lobbied heavily to bring it here because we want to have less shunts in the world. A shunt is a life-saving device, but we need advancement. And there's important optimism here. It speaks to our capacity for our team and for the health system as a whole to be recognized as a center that can be on the very cutting edge of bringing very creative solutions to our patients.
So what happens after the trial is complete? How soon could patients outside the trial access e-shunt if it is approved?
Right. Well, after a trial is performed, there's a pre-designated follow-up period where the patients will be analyzed for their response to the treatment in both arms. And then that data will have to be accumulated and calculated and the outcomes determined and published in a peer-reviewed, publicly available paper. And then that data will be reviewed by the FDA and a decision will be rendered following a rigorous process as to whether or not that device has a place for the public at large. It is the most rigorous medical vetting system in the world. It is the gold standard. I would expect it to take at least a year after the trial, possibly two. What do you think, Dr. Matuk?
Yeah, I think that's well said, and I think 2 years. One of the nice things about eShunt, and again, I think based on the very exciting preliminary data and how safe the device has been, is that the FDA has approved it along a track called breakthrough designation, and what that does is it allows for a little bit more rapid implementation or approval of things that are thought to be particularly impactful to the U.S. public.
Be sure to ask your questions. Use the chat on YouTube or Facebook. You can email the Medical News Network. That information is there on your screen. Dr. Matuk, where do you see the field of NPH treatment going in the next 10 years or so?
I think the first thing is that there definitely needs to be more emphasis on correct diagnosis to try and help establish who might benefit from the procedure. Number two is that I think that NPH is what we refer to as a heterogeneous condition, meaning that it's likely 4 or 5 different conditions that we don't know how to distinguish, sort of pooled under one name, trying to figure out exactly what the different types of NPH are, especially in the context of who's most likely to improve with things like e-shunt and VP shunting, I think is another area for investigation. And then third is to try to further improve the cognitive benefits that can be realized with treatment. Right now, with standard shunting and with e-shunt, we don't expect the cognitive improvements to be dramatic. And I think even though the walking and urine function can increase or improve dramatically. And so drug infusions potentially through the e-shunt mechanism that are meant for neurorestoration or improved brain function, cognitive function, I think is another area that's very exciting.
Well, on that note, Dr. Ebersol, could this same idea, the same technology be used to treat other conditions? Are there other clinical trials testing this approach?
I think importantly, reconnecting the CSF space with the venous compartment, the natural mechanism of the brain, is an elegant approach. And so we hope that it can help to treat other forms of hydrocephalus beyond normal pressure hydrocephalus. That's clearly the first step. Dr. Matuki is a visionary, thinking out of the box, delivering chemotherapy and agents like that through the device, something I'd never even thought of. It's very exciting.
Let's get to some questions from our viewers this morning. And Stu wants to know, he says, I know the FDA treats drugs and devices differently. Is this considered a device, and does that mean the approval process is less rigorous? Dr. Matuk?
So I think what the question alludes to is that there are different tracks or mechanisms that are required to be followed for things that are labeled drugs and things that are labeled devices. I wouldn't think of it as one pathway being easier than the other pathway. They're just different pathways. And what Dr. Ebersol mentioned earlier is that the FDA is the most rigorous body for device and drug approval in the world. And so I think very high standards have to be met before they are available to the U.S. public. And I think that's appropriate.
Jeremy has a question. For trials like this, how do you get involved? Is it something your doctor recommends if you fit the criteria, or is there a route for someone who just thinks, I want to help with clinical trials, help advance science? How does that work?
Well, for our institution, we have sent out information to the providers in the region to let them know that we are working towards opening the clinical trial and recruiting patients for it. But the key is the community identifying the patients that have the condition in the first place and referring them to facilities that have treatment. Not everybody will qualify for the clinical trial, but they can have outstanding improvement in their quality of life if the diagnosis is made, because the shunt absolutely works. The clinical trial is hoping to advance something that may be better tolerated from the patient's perspective, but the classic treatment actually works, absolutely works for the well-identified patient. So if you or your loved ones or a friend seems to be experiencing the symptoms, following with their primary care doctor and raising the point, could this possibly be normal pressure hydrocephalus? It will start the workup to determine if that diagnosis will fit. If the diagnosis fits, if you are at the University of Kansas Hospital, we will determine whether or not you're a candidate for treatment, and we will consider if you could be a candidate for the clinical trial.
Stuart wants to know, what about reservoirs? Can fluid be kept in a reservoir implant?
I think the key is the brain is continuously making this fluid. As long as the brain is receiving blood supply, meaning you're alive, the fluid is being filtered off. So you need something that continuously evacuates the fluid at a similar rate. So the shunt does that when you get it dialed to the right pressure setting. The e-shunt does it by reestablishing the natural physiologic pressure gradient utilizing the natural pressure gradient between the CSF space and the vein. So having a reservoir would be complicated by, it would be a storage compartment.
Yeah.
It needs continuous removal.
Drainage.
Yes, recirculating.
Gotcha. Okay, Dr. Matuk, Amy wants to know, are most doctors taught about NPH? How are they supposed to give an accurate diagnosis?
That is a good question. We're taught a lot of things in medical school. Whether we remember all of it, to diagnose a patient with it is another story. And again, part of the issue with NPH is that as you get older, your hips and knees fail, your back hurts, you don't walk as well. You have balance issues. You can't hold on to your bladder as well as you could have when you were younger. And you have some cognitive issues. And we sort of view that as part of the normal aging process. The issue is that when it becomes, when it advances to the point where it's interfering with your quality of life, right? Your ability to do the things that you want to do with the people you want to do them with. There are things potentially that can be done. And I think that's a reasonable trigger to start thinking about the diagnosis of NPH, which the next step would be to get the imaging to see if you have those enlarged fluid-filled spaces called ventricles in your brain. I think that's what I would want people to know about NPH, is that don't just blow your symptoms off as normal aging, that if you do seem to have these symptoms and they are disabling, they're interfering with your ability to enjoy yourself in your older years, you should ask your doctor specifically about the diagnosis.
Dr. Matuk, so great to have you joining us today. Great to have another brilliant expert with us to talk about this. As we take off today, what's the big takeaway from this conversation? What do you want people to really know?
From my perspective, you have a great medical center, and we're tremendously honored that they've agreed to participate in this trial, and that if you're having symptoms, you should reach out. If you're regionally close to Kansas Medical Center, to your doctors, ask them to put in referrals, and you're going to get an outstanding evaluation for NPH. And even if you don't qualify for the trial, like Dr. Ebersol said, regular shunts work great too, and they can maybe potentially significantly improve the quality of your life. I think that's what I'll leave folks with.
Dr. Ebersol, what's the big takeaway today?
Yeah, I agree. These symptoms happen to all of us as we age. But if it seems like it's happening at a rate that you think is different than your peers, raise the question with your primary doctor, because if the diagnosis is made, you can have very meaningful improvement in your quality of life. Because the other conditions that this can mimic along the dementia spectrum, we right now do not have a treatment in that set of conditions that is as meaningful as a VP shunt, or potentially in the future an alternative like the E-shunt.
Thank you both for the education this morning. We appreciate your expertise. Thank you to our viewers for being with us today. We'll see you back here on Monday. Coming up Monday on the Morning Medical Update. His first doctor said it was a benign cyst. His mom said to get a second opinion. I'm Jessica Lovell on the next Morning Medical Update. The motherly advice that helped catch cancer early. How this man's treatment inspired his new career. Monday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now everywhere podcasts are available.